You may be thinking you will be watching a video of somebody being intubated and see how the technique of inserting the endotracheal tube through the mouth into the vocal cord and into the trachea. Unfortunately, this video series will not have that video for the following reason. First, I could not shoot a live video of somebody being intubated at our facility because of their policies. Second, this is a skill that has to be learned hand-on. You have to learn it from somebody experienced, from an experienced provider. You need to be supervised and guided by that person. Whatever video you watch or text you read, unless you do it hand-on, you're not gonna learn this skill. Third, the technique itself is only part of the endotracheal intubation procedure. That's what I'm trying to emphasize in this video series. Your success of increasing the ET tube, the endotracheal tube, through the mouth, vocal cords, and into the trachea will be greatly increased if you know everything surrounding this procedure. And that's what I'm going to talk about in this video series. So we're going to talk about when to think or consider intubations of a patient. And if yes, the patient needs to be intubated, is there any contraindication to intubate that patient? And if you decided to proceed with endotracheal intubation and no contraindication, how comfortable are you with the intubation procedure itself? Do you need somebody experienced to be there as a backup for you? Is difficult intubation anticipated based on the patient factors? Based on the history, maybe neck injury, maybe C-collar in place, maybe the patient is morbidly obese with an obese short neck. How to prepare for the procedure, the personnel you need to be at bedside, the devices you need for successful endotracheal intubation. What type of laryngoscopy you're gonna use? What kind of a blade you're gonna use? What size of endotracheal tube you're gonna use? How to sedate the patient? Do we need to paralyze the patient? And if we need to paralyze the patient, how to paralyze that patient? How to monitor the patient right before, during, and after the endotracheal intubation procedure? What to do if taking longer than expected to intubate the patient? And should you keep trying intubating that patient? And finally, how to confirm that ET tube is in the correct position and what to do right after that. How to monitor after the ET tube is confirmed to be in place, and then placing them on the ventilator, and where do you place them. These are the topics we're going to cover in this new endotracheal intubation video series. I will try my best to make this as close to reality as possible. So before we proceed, make sure to subscribe to our channel if you have not done so, and make sure you like the video and share it with your colleagues if you find it useful. Let's not waste any time and start right away. When to consider endotracheal intubation in a patient? I could simply list the indication for endotracheal intubation and being on a mechanical ventilation and just go over them quickly. Instead, I'm going to give you clinical scenarios, real patients' clinical scenarios with some modification, of course. I will ask at the end of each scenario, would you intubate them or not? And I'll pause the video for 10 seconds after that so you can think and pick your answer, and then you see if your answer is wrong or right. If you don't mind leaving in the comments if you got most of them right or some of them right, or if you agree or disagree. These clinical scenarios actually will describe 90% of cases that you will see in real life practice in the hospital when you need to consider endotracheal intubation. So let's not waste any time. Let's start with the clinical scenario number 1. A 74-year-old lady had hip surgery for hip fracture. On post-op day 2, she was obtunded. The patient was still vitally stable, still breathing on her own. ABG was looking really good, no hypoglycemia. She did not receive any narcotics, but was really obtunded even to deep pain stimuli. Would you intubate this patient or not? So whenever you have somebody obtunded, you need to calculate their GCS. And clearly in this lady, she's completely obtunded. She's not responding even to deep pain stimuli. They already thought about hypoglycemia, about narcotics overdose, and these are the quick things that you need to think about because they are quickly reversed. So if it's hypoglycemia, you can treat it quickly. If there is narcotic overdose, you can, of course, quickly reverse it with naloxone. But this lady, you should not waste any time and you should intubate her because she was completely obtunded and her GCS was clearly less than 8. What happened in reality for this patient, she was not intubated and a few hours code blue was called and she did not make it. So rule number 1, somebody with GCS, Glasgow Coma Scale, 8 or less, obtunded, especially if you see them started to drool, that means their level of consciousness is not enough or adequate to protect their airways. Remember that well. Don't be deceived by normal vital signs, normal oxygenation, and oh, they are breathing. If they're not responding to strong pain stimuli, you better go ahead and intubate them unless you're able to quickly reverse that. And then after that, you protect their airways, you start your workup why they are so obtunded. 80-year-old patient with long-standing history of partial seizures came in with non-stop seizures. Still partial, still awake, but he doesn't stop from seizing. Neurology involved, numerous doses of benzodiazepine, multiple anti-epileptics medication were given, those seizures non-stop. And to complicate things, the patient was do not resuscitate, do not intubate. The neurologist decided to give the patient phenobarbital as a last choice. If the patient was full code, would you intubate or not before giving phenobarb? Whenever you're going to give a medication that will significantly alter respiratory drive and decrease level of consciousness, you better prophylactically intubate these patients. So with status epilepticus, if we decide to give propofol, for example, we're going to intubate them. In this case, this elderly gentleman, we decided to give phenobarb. We know phenobarb is very sedating, especially when you load them with that at this age. So we talked to the son of that patient about intubating him. Of course, he declined and he said, no, try it. If it works, it works. If not, we'll see what happens. Phenobarb was loaded and unfortunately the patient stopped breathing, was not intubated, and he was pronounced dead. So whenever you're gonna give a medication that will affect level of consciousness and respiratory drive significantly, you better prophylactically intubate these patients, and status epilepticus is a clear example. A 21-year-old gentleman with severe alcohol withdrawal and severe agitation despite large doses of benzodiazepine. The decision was made to transfer him to ICU and the intensivist decided to put him on propofol. Would you intubate him before or not? Of course, this case is similar to the case we just talked. This medication probably will sedate him heavily, especially when we use propofol, something we use to induce anesthesia. You better prophylactically intubate them, and then you can use this medication to control their withdrawal. So severe agitation to the point that you need a medication that will be very sedating, you better prophylactically intubate these patients. 51-year-old patient with alcoholic liver cirrhosis came in with severe upper GI bleed from esophageal varices. The patient was also very lethargic from hepatic encephalopathy. Was still awake, GCS was around 10 to 11. Gastroenterologist came to do upper endoscopy and asked us to intubate him before they do the procedure. Would you intubate? Would you agree with him or not? Of course, the patient is very lethargic. He's gonna receive more medications to sedate him during the procedure. So it's better to prophylactically intubate him for the procedure. And don't forget that their bleeding may worsen and put them at risk of aspiration as well. Another patient with alcoholic liver cirrhosis and massive upper GI bleed, keep vomiting blood. Would you intubate them or not? Of course, these patients at risk of aspiration and at risk of hemodynamic instability and will be in hemorrhagic shock soon. So whenever there is massive, constant hematemesis and vomiting blood, you better intubate them as quickly as possible to secure airway protection and try to control their bleed, of course. A 21-year-old type 1 diabetic came in with DKA. He's huffing and puffing with Cosmal type of breathing, and he has severe metabolic acidosis with his pH around 6.9 and bicarb is too low to measure, PCO2 around 15 and PO2 was very stable. Would you intubate this patient or not? Severe metabolic acidosis, usually it's an indication to intubate this patient because most of the time indicate the patient is hemodynamically unstable and in shock state, except in DKA. These patients usually quickly respond to the treatment and we rarely need to intubate these people. What they need, fluids, insulin, and quickly their condition improve. So I don't tend to intubate these people unless their GCS fall to 8 or less than 8. Otherwise, quickly give them fluid and insulin drip and you should quickly reverse their clinical condition. ABG which would be much better. So most of the time, there is no need to intubate these people even with severe metabolic acidosis state. 75-year-old lady, hypotensive with severe metabolic acidosis and simply she's in septic shock from UTI. Her pH is around 7, lactic acidosis is 12, and bicarb too low to detect, CO2 around 25, PO2 was stable. Would you intubate her or not? Absolutely. This patient is hemodynamically unstable. She's in shock state, severe metabolic acidosis. She's not compensating well. And it's better to intubate her now, even if she's awake, because soon she will become obtunded and lethargic. And we don't know how quickly, if they will respond to the treatment, how quickly they will respond. So I would go ahead and intubate this patient. And this applies in general to hemodynamic instability and shock states, because these patients, even if they are awake now, soon will become obtunded or lethargic. So it's better to intubate them as soon as we can. Again, the exception is if you feel things can be reversed really quickly. But most of these shock states, hemodynamic instability states, severe metabolic acidosis states, which we would like to intubate them quickly before it becomes a true crashing emergency. A 70-year-old lady received 3 units of backed RBC's blood and 2 units of FFP. Few hours later, she became suddenly very short of breath and respiratory distress. Her autosat was declining, was around 88%, on non-breather 100%. Would you intubate that patient or not? Of course, this patient is setting 88 to 89, so this is not too bad. She's in respiratory distress, she's a non-breather, and clinically I can guess why she is hypoxic. Most likely she has pulmonary edema. But on top of that, I still have a choice. She's still awake. I still can use non-invasive positive pressure ventilation like CPAP. So I still have that. I still need to give that Lasix and, treat her for pulmonary edema. So I think there is a chance I could save her from being intubated. So whenever the hypoxia is not too bad and still you have something to offer the patient before being placed on mechanical ventilation and something you can treat, do it. Remember, endotracheal intubation should be last resort to most of our patients. So this patient, we use CPAP, We gave her Lasix, gave her some morphine, and she improved and did not need to be intubated. A 68-year-old patient with diffuse bilateral infiltrating chest X-ray from COVID-19 pneumonia. His PO2, believe it or not, was 39. He was short of breath, of course. He was on CPAP, requiring 100% FiO2 and CPAP of 10 centimeter H2O, and with that, his PO2 was that low. Would you intubate or not? Of course, the PO2 is too low. The patient will crash soon. It's a matter of time until the patient crash and code blue cold. So the patient, whenever there's profound hypoxia, it's better to go ahead and intubate the patients. When I say profound hypoxia, is the patient is like autosat is in 50s, 60s, despite being on 100% of FiO2, or PO2 in 40s, 30s. There is no time. The patient will code soon, so you better go ahead and intubate. This patient was intubated, and despite that, unfortunately, did not make it. So this, in comparison to the previous case, the autosat, the hypoxia was not too bad. We have something to offer. This patient was profoundly hypoxic, despite being on 100% of FiO2. Now, whether CPAP or non-breather or whatever, vapotherm, the high-flow nasal cannula, when the autosat is too low with 100% FiO2 despite the device, there's really no time for us. Go ahead and intubate the patient. Try to fix their oxygenation as quickly as possible. 64-year-old lady with history of COPD came in with worsening shortness of breath for a week prior to admission. In the ED, she was lethargic. Her pH was 7.1, PCO2 around 85, PO2 was around 75 on few liters of oxygen. Would you intubate this patient or not? Of course, whenever we have hypercapnia, BiPAP come to our mind. But remember, this patient has an altered mental status. She's lethargic. So BiPAP or non-invasive positive pressure ventilation would be contraindicated in this patient because there's a risk. They are unable to protect their airways. They may aspirate. So whenever there is altered mental status or lethargy or change in mental status with hypercapnia, you better just go ahead and intubate them. And actually, altered mental status is always a bad sign when you add it to the initial problem. Like somebody hypoxic and altered mental status, of course, I would intubate. So whenever there is altered mental status, make the decision to intubate easier. Of course, unless it's something you can reverse quickly. It's somebody hypoglycemic or somebody with a drug overdose that can be reversed. If it's not reversed, of course, you need to intubate them. So this lady was intubated in the emergency room, extubated 3 days later. A 72-year-old patient with COPD, shortness of breath for 3 days prior to admission in the emergency room, diagnosed with COPD exacerbation. His pH was 7.15. His PCO2 around 75. PO2 was stable. He was a little bit tachycardic, tachypnic. And mental stats wise, he was still awake and we had a good conversation with him. Would you intubate this patient or not? Of course, this patient has hypercapnia and respiratory acidosis, but still awake. We had a conversation with him so that clearly he's able to protect his airways. So we should try first, before we jump to endotracheal intubation, mechanical ventilation, we should try BiPAP and treat his underlying COPD exacerbation. We did that, he responded well, and he ended up going home and did not need to be intubated for that reason. So you could see the difference between this case and the case before is that the altered mental status. The mental status here, patient is wide awake, able to protect his airways despite his breathing a little bit fast. But that lady on the previous example was lethargic. So that's the main factor in deciding to intubate or not. Now, the pH can be a factor, but even if the CO2 is 100 and the pH is a 7, if the patient is still awake and we still can use a BiPAP, there is an argument. We should just use a BiPAP, give a chance, do it for 2 hours and monitor the patient. If it works, great, we continue that. If not, intubate. Of course, on the other hand, some will argue, said, no, we should intubate them right away. So the mental status is very important in the case of hypoxia or hypercapnia in making that decision and whether we should use BiPAP or not. Just go directly for endotracheal intubation. A 19-year-old girl came into the ED with severe sore throat, inability to swallow because of that. She was in distress, she was drooling, tachycardic, febrile. Oxygenation was still good, blood pressure was still good, and she was, of course, drooling. Would you intubate her or not? The ER physician in this case immediately suspected epiglottitis, and he was quick, and he intubated her quickly, and that's an indication. Whenever you see somebody drooling, unable to swallow, always think either they are unable, there's something going there, like severe sore throat, peritonsillar abscess, something can compress and close their airways, or their mental status is too bad to be able to protect their airways. In both cases, it's always an indication really to quickly intubate these people. 49-year-old lady, history of anxiety. In the emergency room, they called for rapid response, respiratory rapid response to intubate her because she was breathing too fast, she was tachycardic, but oxygenation, she was a non-breather, her O2 was 100%. Listen to her, good breath sounds, good air entry bilaterally, no issues with that. Blood pressure is stable, she was tachycardic, tachypneic. Would you intubate her or not? This can be very challenging because people around you, oh, she's in distress, she's gonna get tired. And on the other hand, you say, her oxygen is good. You may do an ABG, and that can give you a clue. You see, they're just hyperventilating. They just CO2 is too low, but PO2 is very well. So whenever you have that, and there is an underlying history of anxiety, panic disorders, you better just calm this patient, give them some benzo, just break their anxiety, and just monitor them closely. There is no really need to rush and intubate these people. Again, in the case we had, I remember that everybody was pushing to intubate, and me and my co-residents, we resisted that despite all the pressure. We gave her some benzo, and eventually she calmed down, and we didn't need to intubate her. So these clinical scenarios will cover most of the cases you will encounter in the hospital. Of course, we did not cover 100%, but these are real clinical scenarios. Now, of course, most of these cases I mentioned, they need urgent or emergent endotracheal intubation. Now, there's something called elective endotracheal intubation, and mainly we see it in the OR for elective surgeries, right? For surgeries in general, you electively intubate these patients. And this is a perfect time to tell you that OR, rotation with anesthesia, would be a very good starting point to sharpen your endotracheal intubation skills. It's a control setup. You have somebody experienced to supervise you. Most of these patients are healthy to start with. It's the place to start learning endotracheal intubation with direct or indirect laryngoscopies. So that's my advice to you. If you want to start and you can do a rotation with anesthesia in the OR, that's a perfect really place to start learning this skill. Also, there's some other procedure, not surgeries technique, like ERCP. Patients need to be intubated for this. So this can be elective endotracheal intubation. Some cases like somebody who's lethargic, and we just mentioned that in one of the clinical scenarios, and let's say they need an endoscopy, they want you to intubate them, just they're afraid they will stop breathing during the procedure, or they about to undergo bronchoscopy, similar things. Also, you can consider that semi-elective, semi-urgent, depends on the underlying clinical situation. I hope these cases will give you an idea on the real life scenarios you will be encountering and the decision that you need to make. At the end, everybody will be looking at you to make that decision. The nurses will not make it for you. The respiratory therapist will not make it for you. Your intern, if you're a senior resident, or if you're an attending, your residents will be looking at you. So you need to be decisive, know your stuff, and make the best decision for the patient. And remember, you need to be one step ahead. If you do things one step ahead, you prevent a true full emergency or a crashing patients. Most of crashing patients, or all of them actually, they always give you some clues, some subtle signs prior to that. So if you catch them, and this is something that comes with experience, you act on them quickly, you can prevent a full emergency, a crashing patients. Next video, we'll talk about what to do next once you decide this patient needs to be intubated. So I'll see you next video.